Well, thanks for coming. We're going to talk tonight about obesity, something that I'm pretty passionate about. As Mike said, I am actually board certified in family medicine, but I'm also board certified in obesity medicine. When Mike first talked to me about doing this presentation, obesity is very broad. I wound up having like 830 slides and didn't think I could fit it into this 6 to 8 hour lecture. No, actually, it's not going to be 6 to 8 hours. But I tried to whittle it down and try to get it down into not so much the statistics, because I think everybody who's here probably knows about statistics, but we're going to talk about a plan to help treat and prevent obesity. Okay. I tried to get away from all the stats, but everybody kept telling me you gotta state why you're here. So these are the big stats. These were actually taken from the CDC this month. Basically, it shows that from so in 2000, the obesity rate in the United States was about 30%. About 1 in 3 people were obese. Since then, since 2017 to 2020, that rate has actually went up to about 42%. People who are obese and overweight, it's 71% of our population. So it's pretty significant. It also costs a lot of weight, or costs a lot of money as far as hospitals and healthcare goes. About 173 billion. Plus, people who are obese or overweight actually have a higher medical cost than people who aren't. This shows what the last slide shows in a graph. It shows the average weight of men and women have both went up pretty much congruently over the last, since 1990 to 2008, and that has continued to rise. Definitions, it's always important to define what we're talking about. This definition, I know it's sort of verbose and wordy, but this is actually the definition that the Obesity Medical Association and the Obesity Society, which are the two big groups that help with the understanding of obesity, came up and sent it to Congress. So they actually had, and this was approved in 2015. Before 2015, Medicare, Medicaid, Congress did not recognize obesity as a disease. They thought it was a body habit or a weak-minded people or lack willpower, and we know it's farthest from the truth. People talk about treating diabetes as a very hard thing. Diabetes, you're really dealing with just insulin and glucagon, 2 hormones. Obesity, there's about 120 to 126 different hormones that we've found that control obesity. So significantly harder to deal with obesity than it is to deal with diabetes. This is sort of a slide that shows in a format what the last definition is. Obesity does have both genetic and epigenetic roots to it. So some of this is inherited. There is some environmental causes, both social habits, neurobiological. We'll talk about a lot of the neurobiological medications at the end. Endocrine, of course, we're talking about insulin. We'll talk about that. Bunch of medical comorbidities, and it actually affects the immune system, and we'll talk a little bit about that. So back to definitions. 3 basic ways that we look and determine what type of obesity you have. The first one is BMI, it's body mass index, which is basically your weight divided by your height squared. It's not the perfect measurement, but it's the measurement that's used probably about 80% of the time to diagnose obesity. Normal weight is between 18.5 and 25. Overweight goes from 25 to 30. Class 1 obesity is 30 to 35. Class 2 is 35 to 40. Anything above 40, we call it class 3, or the old term used to be morbid obesity. We try not to use that word too much. The other way of doing it is actually through abdominal circumference. We find that abdominal fat and visceral fat is actually a lot more pathogenic than fat that's on your arms and on your legs. So these are classifications for men. Anything greater than 40 inches, you're considered obese. Any women, it's 35. This does fluctuate a little bit with cultures, different races. It's actually lower for Asian men and women. It drops down to 90 centimeters and 80 centimeters, respectively. The other way, and I think this is actually a very, very strong slide. I found this picture a little while ago. This shows that your skeletal system remains the same no matter how much adiposopathy or adipose fat that you put on yourself. Okay? And the third way of determining, classifying obesity is actually through percent body fat. Basically, anything above 35 in females, or 35 in males, or 35 in females and 30 in males is considered obesity. Now, multiple ways of determining percent body fat. The hospital actually does a DEXA scan now. They'll let you do a DEXA scan to get to determine fat mass for like $75. It's relatively cheap for a DEXA scan. We can do CT scans, and if you've ever had an abdominal CT scan, they can actually calculate body weight from that, or fat percentage from that. There's also bioimpedance scales that you can step on, and it will tell you what percent muscle, what percent fat, what percent water, what percent bone you're on. So that is the definitions. A lot of people ask me, why do the definitions matter, and how are these numbers, were these numbers arbitrarily picked as far as BMI and percentages in that? And they actually weren't. They did a all-cause morbidity trial, and it was found that people who are in the normal weight range from 18.5 to 25, they have the lowest percentage of deaths per 1,000. When we get slightly above into the overweight category, you have a slight uptick, but then when you get into the obesity, you start having an exponential increase in deaths per 1,000. And this is where those categories came from. If you look at the statistics, it shows that as we go up in BMI, your health decreases. Now, this is all-cause mortality. It's adjusted for other risk factors like smoking and habits and all that stuff. It's pretty strong research, and that's why they came up with those. The other thing that the reason obesity is so important, that obesity last year just took over for the leading cause of cancer. You know what used to be number one? Smoking. Used to be the number one cause of cancer. It was overtaken by obesity last year. So 50% of all cancers are caused by obesity. Obesity itself is an inflammatory. It causes inflammation in the body. We'll talk about that when we start talking about insulin. And that inflammation causes irritation to the tissue, and that tissue winds up going through what's called metaplasia, changing to help defend itself against that inflammation, and can cause all these different types of cancers. With obesity, there's actually two different ways that it affects the body. One is through the endocrine and immune response derangements. That's through insulin causing inflammation. It causes blood pressure to be elevated. It causes blood sugars to be elevated. It causes, because your blood sugar is elevated and insulin's there, it causes hypertriglyceridemia, which increases cholesterol, which then cholesterol causes a whole bunch of cardiovascular problems. So that's this side. The other side of the story is what the orthopedic surgeons worry about, and that's the actual fat mass itself causing stress on weight-bearing limbs. It causes osteoarthritis to the knees. It causes hip replacements. It causes ankle problems. It causes bad backs. And all that is related to the actual fat mass itself. It can also cause other things that you don't think about, like obstructive sleep apnea, Pickwickian syndrome, which is when you have too much weight on your diaphragm. You can't breathe very well at night. It can cause GERD, gastroesophageal reflux disease. So it can cause a lot of other, just through the fat mass. Obesity is one of the major drivers of aging. Believe it or not, we don't know why we age. It's sort of a weird conundrum in medicine, but nobody has a overall, hey, this is why. We used to think it had to do with telomeres and that's been disproven. So we're not quite sure why, but we know that obesity, through dysregulation of nutrient sensing, which we call insulin resistance, high blood sugar, high blood pressure, increased lipids, increases cardiovascular disease, which is caused by endothelial. So endothelium means the skin inside your arteries, especially your coronary arteries, they don't constrict and dilate the way they should. That's the endothelium, which then causes cardiovascular disease. And then once you get cardiovascular disease, everything starts going downhill. And believe it or not, the same process that does obesity, diabetes, metabolic syndrome, cardiovascular disease, they're all on a spectrum. And insulin resistance is the first sign of that you're going down that pathway. And if we could stop you from going down that path at that time, we can save a lot of downstream trouble. Fair enough? So that's the statistics definition. The rest of the time, we're going to talk about a program to help prevent and treat adult obesity. I didn't think there was going to be a lot of kids in the audience, but I know some of you guys are parents and some are grandparents, and childhood obesity really needs to be addressed. It's actually becoming a worse problem than adult obesity is. So I just want to talk real briefly, if you're concerned about children and grandchildren, what we do for children, we don't necessarily try to make them lose weight. We want them to grow into their weight. But there is a program called the 5-4-3-2-1-0 program that works statistically. It works very well. I have several of my pediatric patients on this, and if they stick to it, it helps immensely. So what is the 5-4-3-2-1 program? 5 is you need to eat 5 fruits and vegetables a day, which doesn't sound like a lot, but if you talk to kids, they think French fries is the ultimate vegetable. And the caveat with the vegetables and fruits, they have to be as close to nature and as raw as possible. So you get them to start eating broccoli and cauliflower and you know, everybody knows bananas, but that's about it. And get them introduced to different fruits and vegetables, make it different. Usually we give them a calendar. We give them little gold stars. We actually have a little V that we give them for vegetables and gold stars for fruits. And I'll give them a calendar, and every time they eat a fruit or vegetable, they'll put a star on. And then every time they come see me, I get to see their calendar, and we get to say, hey, have you tried cherries this time? Or have you tried, different fruit or different vegetable? We usually start with just fruits and vegetables, and then we go to fruits and vegetables. The sort of the science behind this is if you're eating 5 fruits and vegetables, you don't have space to eat the junk food. So you're sort of substituting very calorically dense food to non-calorically dense food. 4 is they should eat 4 meals with the family. It used to be when I grew up, I would say out of the 21 meals that I ate a week, breakfast, lunch, and dinner 7 days a week, 21, probably 19 of them was with the family. Now, it's 1 or 2, and we're trying to increase that because we find that when we have kids and families sit down at a table, they eat less and they eat healthier. 3 is they need to cook 3 meals a day. Probably one of them, or 3 meals a week, not a day. That'd be a lot of meals, right? 3 meals a week. It's very important that we teach kids how to eat. I've had more than 1, more than 2, more than 3. Mid-20 people come and see me for weight management. And I ask them, what do you eat? And they say, well, today for breakfast I stopped at Sunrise and had a bagel, egg, cheese, sausage, bagel, and I had a foo-foo coffee. They always tell me, but I can never remember what they had their coffee. And then for lunch they went to McDonald's or they went to Wendy's or Arby's nowadays. For dinner they eat at Kentucky Fried Chicken or Pizza Hut or Taco Bell. And I look at them and say, you do that every day? And they say, yeah. I said, do you know how to cook? And they'll say, yeah, I know how to cook. I know how to cook ramen. I know how to cook macaroni and cheese. And I know how to make cereal. And I'm like, oh, I've got my work cut out for me. I find this more in the 3rd, 4th, and 5th kid than I do the 1st and 2nd. But I think it's very important that kids learn how to cook meals so that things don't go awry when they get older. Number 2 is the Pediatric Society says that we're supposed to limit our children below the age of 18 to 2 hours of video time, screen video time. Any of you guys have grandchildren or children that are on video? How many hours do they spend? Usually it's on the weekend. It can be up to 14 to 16 hours on video time. I modify this and say for every 2 hours of video time, you owe me 1 hour of exercise. The good thing about some of the video games now, some of them are becoming interactive and more, I know Beat Sabers, and there's a couple other role play games that you actually have to move and have exercise for. So that's 2. 1 is at least 1 hour of physical activity, unless of course you're doing 10 hours of video and then you owe me 5 hours of exercise. It doesn't always work, but we try. And then 0 is 0 sugar sweetened beverages. Study after study after study shows that people are drinking sodas and drinking juice. And yes, Capri Sun is just as bad as a soda, and Sunny Delight, you don't even want to read the ingredients on that. It's not good. So you just sort of need to, so this is the 5-4-3-2-0-1 program. Any questions on this? Because I'm going to start talking about adults here. Go ahead.
I have a question. So for the bottom one with the sugar sweetened beverages, what's the, I know there's real sugar drinks and there's a whole bunch of these artificial sugars. Is there any better stuff between diet soda and normal soda? I know one's artificial, one's not.
Yeah, that's a good question. The artificial sugars, unfortunately, especially the sucralose and the aspartame K. Sucralose, if you know a lot about chemistry, it's an artificial sugar that actually has 3 molecules of chlorine bound to it. That's the chlorine bonds to the molecule actually make it so that you can't break it down. That's what makes it non-nutritive. What do you use chlorine for? What? Cleaning stuff, right? I work in an office. At the end of the day, we take chlorine and just clean everything, right? Well, unfortunately, because those 3 chlorine molecules can't be broke off the OS molecule, the sugar molecule, it's going right through you and doing exactly what chlorine does, and it's cleaning your gut biome. Your gut biome, you're made up of several trillion cells. Your gut biome was may have about 10 times that amount. Believe it or not, there's more not you cells than you cells living in your body. Those eat calories for you. They burn calories. And you're killing them by the millions with your artificial sweetener. So I tell people, you really don't need to drink regular soda or diet soda. You know, water works great, seltzer water works great, tea works great, iced coffee works great, coffee works great, milk's good. All those things, you know, there's about 2,000, 3,000 teas that you can find here in Fairbanks. You know, passion fruit tea, put it on ice, pretty good. You know, you don't need to add a bunch of sugar to it. So that's sort of where I fall out on the sugar sweetened beverages. Does that make sense? The other thing that they found with the artificial sweeteners, especially with kids, this is the pediatric group, it tends to have a higher association with ADHD and a thing called OD, which is offensive, appulsive. It's when kids are very defiant disorder, appulsive defiant disorder. So fair enough. So just try to stay away from, if you don't know what it is, why are you putting it in your body is a better thing. So fair enough? Good question though. So let's go on and let's talk about a program. Our program at Gold Star, we basically, and this mirrors the Obesity Medical Association a little bit, not exactly, but what we do is we build a table, okay? So the tabletop is going to be the physician's responsibility, mine, I have a couple of nurse practitioners, anything that can cause you to gain weight or prevent you from losing weight. And then there's going to be 4 legs of the table. Let's talk about the tabletop first. These are all the things that can prevent you from losing weight, and we have to fix them before I can help you. One is medications. I can't tell you how many times I've had people come and looking at the medication that their physician has them on, it's causing weight gain. And I actually have a slide on that. The other one's type 2 diabetes, insulin resistance, and metabolic syndrome. Those are all 4 related to insulin. We're going to talk about insulin in just a second. I don't have slides. I couldn't fit slides for all this stuff, but I don't have slides for the vitamin deficiencies. But if you don't have vitamin B12 converts food and fat into energy. If you don't have B12, it's going to be really hard to lose the weight. It's also going to have a real hard time having energy to lose the weight. So we checked at anemia and iron deficiency the same way. If you're anemic and you're iron deficient, you have no energy, you're not going to be motivated, not going to be able to lose weight. Cushing syndrome has to do with cortisol production. Thyroid, we all know if you have no thyroid, you have no metabolism. Hypogonadism, we check that in males a lot because if they have insulin resistance, insulin is the hormone that can produce fat. If they're low in testosterone, which is the hormone to produce muscle, it's sort of not a level playing field, is it? I mean, how do you expect somebody to lose weight and become fit if they have all the hormone to gain weight and no hormone to gain muscle? So we check on that. And then there's a bunch of genetic disorders. We do have a agreement with Rhythm Pharmacologics that we actually do a genetic testing. They test for 88 different genetic causes for obesity, and they do it for free. So we do, if you think you have genetic associated disorders, we can do that. So let's talk about medications. Everybody's sort of amazed at medications, but a lot of medications cause weight gain. One of the 2 biggest contributors to weight gain that are medications is one is the narcotics. Narcotics slow down everything in your body. They slow down your gut. That's why you get constipation. It slows down your brain. It slows down everything. The other big, and you usually on narcotics you can gain between 10 and 15 pounds a year. Beta blockers are the other big one. Anything that ends with ol, like metoprolol, atenolol. A lot of people are put on these for blood pressure reasons, which they're not great blood pressure medications, but they're easy to prescribe, so a lot of people do that. They slow your heart rate down. They take your heart rate from about 100 down to 70. If you do the math and you do 30 beats per minute times 60, that would be an hour, times 24 in a day, times 365. You're actually missing about 15 million beats of your heart per year. That's heartbeat, that's muscle, that's contraction, that's you're losing that. And that's just your heart. That's not what it's doing to your gut. It's not because it slows down your peristalsis. Beta blockers cause you to gain 10 to 15 pounds a year also. And I have seen people who have been on beta blockers for 10 years and they come in and they've gained 100 pounds and they don't understand why. And they really, really struggle to lose weight. Hey doc, I'm doing all this, I'm doing this. You know, I go to the gym, I can't get my heart rate up because I'm on this medication that's slowing my heart rate. Well, why are you on heart? Well, my doc started about 10 years ago because I had a little hypertension. Well, why don't we try an ACE inhibitor or an ARB or a calcium channel blocker or a whole bunch of other different medications before we start beta blockers. And you get them off beta blockers, and one, they don't feel like they're walking in mud anymore, and they have more energy, and they're able to lose weight, and sometimes that's all I have to do for folks. There's a lot of other meds, I'm sure you probably read them, but you know, some of your antidepressants, you know, Zoloft and Celexa and all those, they tend to be about 6 to 8 pounds a year that you're on them. A lot of the antipsychotic medications, they're even higher than that. So you have to look at which meds you're on. Remember when we went to we talked about diabetes, prediabetes, insulin resistance, and metabolic syndrome prevent you from losing weight. That's all related to insulin, so I thought we should probably talk about insulin. Okay, insulin has about 120 to 100. Well, when I went to med school, it had 120 uses or 120 things in your body. It's up to about 140 to 160 now. It seems like every time I turn around, there's a new article of, hey, insulin does this, insulin does that. I'm not going to bore you with the whole 2-week lecture in med school. I'm just going to tell you the biggest things that it does. The biggest thing, why you need insulin, is it opens your cell to allow glucose, blood sugar, to go in your cell. It goes in your mitochondria. Your mitochondria turns it into ATP. ATP is what makes us move. It's the energy. It's electricity of our body. Without ATP, we're no longer moving, we're no longer around. So we need insulin, it's very important. That's about one of the only great thing it does. The other things are sort of on the negative side. One is, it is the major fat storing hormone in your body. If any of you guys want to play Santa Claus for Christmas, I can guarantee that I can have you gain about 80 pounds before December. Come into the office, we'll start you on insulin, we'll give you big doses, we'll have you eat so your blood sugar doesn't crash, and your weight will go up like you've never imagined it could, okay? Insulin is to fat like anabolic steroids. You know, bodybuilders, football players use it to build muscle. Insulin is to fat like anabolic steroids to the muscle. The more you take, the more you use, the more you have, the heavier you're going to be. The other thing it does is it causes inflammatory cytokines to be released. So all that achiness in your joints that you have, you know, after you have, you know, you go to Bobby's and have that spaghetti dinner with garlic bread and tiramisu, a lot of processed food there. It's going to cause your insulin levels to go up. Tomorrow morning, you might wake up and your back or your ankle or whatever ails you might start hurting a little bit more than normal. It also turns on mechanisms to both make cholesterol and triglycerides. That's how insulin resistance is the driving force behind cardiovascular disease. It also stops autophagy, which is how our body recycles cells that aren't quite right. This is also one of the reasons that it causes so many of the cancers that we saw before. If your body can't get rid of dysfunctional, degenerate cells, they can actually turn into cancer cells, and that's what that autophagy, and insulin stops that. So if you're insulin resistant, pre-diabetic metabolic syndrome or diabetes, you have to treat it. If you don't treat it, you might as well just go and start beating your head up against the wall because you're not going to be able to get people to lose weight when they have the hormone that causes fat storage. And this is the reason. We used to think fat cells, and this is the onus, or this is the reason behind the insulin resistance. We used to think fat cells, these are my cartoon character of fat cells, used to be inert. We just used to eat a bunch of extra calories. They would go into your fat cell. When you didn't eat, you got starved, what would happen is the calories would go out. And that's all that fat cells did. Well, now we know that fat cells actually produce interleukins and cytokines, which is a really fancy doctor speak for saying hormones. You know, if us doctors didn't use big words, everybody would be practicing medicine, we'd be out of a job. So interleukins and cytokines, just hormones that actually cause the cell, it actually changes the polarity inside the cell. So now instead of needing just one insulin to get the sugar into the cell, now you need two. That causes your pancreas, picture of your pancreas, to increase insulin. What did I say insulin's secondary job is? Fat storage, right? So what happens? We get more fat, which then causes more insulin, more cytokines and interleukins to be released, which causes us to have more insulin, which then causes your pancreas to produce more insulin, and it's a positive feedback loop. Without breaking this cycle, you're going to have a real hard time losing weight. Now how do we break this cycle, I guess is a good question. Well, I'm a family medicine doc. You don't want me taking my Swiss Army knife to your pancreas. Plus, you need your pancreas for a whole bunch of other stuff. So I'm going to leave the pancreas alone. I can tell you to lose weight, like some of your regular docs will say, just exercise, diet and exercise, you'll lose weight. That's sort of equivalent to me telling a young female who's just about ready to go on their period that she can't change her mood. Because what changes the mood? They're hormones. These are hormones, just like that. So these hormones are actually telling your fat cells and telling your brain, hey, I need fed. So we can't just say, hey, just diet and exercise, you'll break this habit. What we have to do is we have to look at the insulin resistance. And that's what we're going to talk about for the rest of the time here. And how do we break insulin resistance? It's through diet, it's some exercise. There are medications that can help. Fair enough?
You said some exercise.
Some exercise does help. We're going to get to exercise ad nauseum. Well, not ad nauseum because believe it or not, exercise has very little to do with weight loss. It has a lot to do with weight management, but not a lot to do with weight loss. But we'll get to that. Any other questions on this slide? I know it's sort of busy and complicated, but this is one of the root causes of obesity, and I think it's pretty important to understand. This is just sort of a slide that shows this happening. You have extra energy flow. It causes fatty influx. It causes a whole bunch of things, insulin resistance. Then you start having muscle dysfunction. Then you get hyperinsulinemia. Your beta cells start dying, and then it's a sort of a positive feedback loop there too. So let's start talking about the table. We talked about the tabletop being anything that could prevent you from losing weight. We deal with that. The patient is now going to be responsible for the legs of the table. The first and the biggest leg is diet. Okay, can't come in my office eating Krispy Kreme donuts, dunking them in Mountain Dew and expect me to help lose weight. It just doesn't work that way. The other thing is if you came here tonight thinking that you're going to get the ultimate diet to help you lose weight, I'm sorry to disappoint. Research shows no such thing. You know, everybody's metabolism is different. Diets have to be sort of specialized to each patient. Normally what we do is we do a lab panel and we look at, hey, what's going on? You know, if you're diabetic, it would be very ridiculous for me to put you on a high carbohydrate diet. If you had kidney disease, it would be terrible for me to put you on a high protein diet. If you have high cholesterol, I'm not going to put you on a high carb diet either, because that's what causes cholesterol. I'm going to let you eat a lot of eggs, but I'm not going to let you eat processed carbs. So how do we deal with diet? Well, I thought about this when I did this lecture, because I had like 18 different diets set up, paleo and keto and Ornish and all these other diets. And I said, now let's boil all the diets down. And basically there's 3 levers that you can pull for all diets. Okay, and those levers are, 1, what you eat. It's probably what I use about 70% of the time. I tell people, hey, if you're pre-diabetic and you have insulin, I tell them, I don't want you to eat anything with added sugar. I don't want you to eat anything with flour, and I don't want you to eat the white starches, white potatoes, white rice. Sound familiar? So that's what you eat. Now, this is also how high fat, low fat, high carb, you're telling people what to eat. Okay, so that's one lever. The other lever is how much do you eat? And that's calorie counting. Now, the research, if you look at calorie counting, in the very short run, people can stick to calorie diets for about 3 months, and then it wanes. 6 months on the outset if people are really, really motivated. The problem I find with calorie diets is if I put you on a 1,200 calorie a day diet and you're finishing lunch and you put everything in your little tracker, because there's a bunch of apps that track calories, and you're at 1,199 calories and it's 2 o'clock in the afternoon, and you think to yourself, holy crap, I got 1 calorie for the rest of the day. And then you start panicking. You know what you start doing? You start thinking about food. What's a 1 calorie food? And then what happens? You're saying, oh, I'm going to blow it today. So why don't we go to the House of Fire and get 3 or 4 pizzas and have one of those, and maybe I'll have a beer with it, and I really like soda, so I'll have one of those too, because I'm blowing it today anyway. And people wind up eating more calories on calorie diets than they would on the other diets. So I don't tend to use calorie. I do use the third one quite a bit, and that's when you eat. This came about, I'm sure you've probably heard of intermittent fasting and time-restricted feeding. This came about from a study that they did. Epidemiologists looked back at the late 80s and early 90s and said, you know what? People in the 80s, it was actually the 70s and 80s, late 70s, early 80s, ate the same amount of calories as people eat today. And you know what? We're not any more active or any less active. Bankers still do banker things. Doctors still sit behind desks. Librarians still do librarian stuff. Teachers still teach. We're not any more active or any less. But the obesity epidemic started in the late 90s. What's the difference? So they looked at a whole bunch of different things. Junk food, no. Junk food was the 50s and 60s. Margarine and Ho-Hos and Twinkies and Oreos, that's all in the 50s and 60s, right after World War II. It wasn't, nothing really, no revolutionary junk food came in existence in the 80s or the 90s. What was the difference? Well, believe it or not, the difference was soccer and CNN. Why do I say that? Well, when we were all young, what happened is we all ate breakfast at breakfast time. We had lunch at noon or whenever school or whenever your lunch break was. And then we all came home and we ate at 5:30. 5 to 5:30, dinner was on the table. Why? Because at 6 o'clock, Dad had to be on the sofa or on his easy chair with his cocktail and his pipe to watch Walter Cronkite. He came out, it was the 6 o'clock news. The only time you got the news was at 6. CNN wasn't invented then. There wasn't a 24-hour news cycle. So everybody at 6 o'clock had to be done, dishes had to be done, Dad had to be on his chair watching the 6 o'clock news. What happened to the kids? Outside with you. Come back when the lights turn on or when it gets dark. And then when the kids came home, what did you do? You made them wash their hands, they brushed their teeth, and they went to bed. There wasn't a lot of Ho-Hos, Twinkies, and Ding Dongs, right? Then let's enter soccer. Soccer came in, and soccer was not associated with a lot of school activity. It was after school. So mom now, instead of being home cooking meals at 5:30 at 6, what is she doing? she's taking Johnny to soccer. So now you're not eating until 7:30, 8 o'clock. And prior to that, what was happening? We were done eating at 5:30, and we didn't eat again until 7 or 8 o'clock the next day. That 13, 14 hours allowed your insulin levels to drop. Without insulin, you can't maintain fat mass. Insulin is sort of like fertilizer to your fat garden. You take the fertilizer away, the garden is not going to thrive. Same thing with insulin. And that's what happened during that time frame is they were able to, your insulin levels were able to drop, and that's why there wasn't a big obesity problem. So that's when the when you eat came into existence. Now, time-restricted feeding, there's several ways of doing it. I have people who they eat in an 8-hour period. They just say, hey, I'm going to start eating at 10 and I'm done at 6. Or they say, hey, I can go until noon. They eat from noon to 6 or noon to 8. I have some people that do 6 and 18. I have some people that do 4 and 20. They eat for 4 hours and they don't eat for 20. Believe it or not, when you start doing that, it actually gets easier. I never tell people to start at 4 and 20. I always start with the 8 and the 16 and then work my way up. We also tend to do, when we're starting to do the 8-16, we also ask people to fast for 24 hours once a week. And then once we get up to the 6 to 18, we ask them, hey, do you think you can do a 36-hour fast? Which isn't too bad if you think about it. So the 24-hour fast, you wake up, you have breakfast, you have coffee, tea, bone broth if you want it, water, electrolyte solution throughout the day. You go to bed, you wake up, next day for breakfast you eat. You don't go a day without eating, but you do go 24 hours without eating. 36-hour fast, you get up one morning, you eat breakfast early, and then you don't eat. You can eat all those stuff that we talked about. And then the next day, you don't eat until dinner, and that's 36 hours. So you never go without a day until you do the 72-hour fasting, and I'm not going to get into that right now because that right now blows people's minds. But once you do a 24-hour and a 36-hour, once you do a 36-hour, you'll never feel better, and you'll want to do a 72-hour fast. But in fasting, there's some myths behind it. One of the big myths is, hey, when you start fasting, you're going to start catabolizing, or you start breaking down your muscle mass. Well, think about it. As we evolved, if you and I were out hunting and you were just about ready to shoot an animal and I stepped on a twig and it ran away and we didn't eat, what's going to happen tomorrow? Because we're not going to eat today. We wouldn't have evolved if it was, hey, you're going to start eating your muscle mass. So what happens at about 28, 30 hours, your human growth hormone, your insulin-like growth factor, both protecting a muscle, increases. So you don't lose muscle mass. I actually had a guy fast for 21 days. Not that I recommended it, but he wanted to do it. He lost 56 pounds in that time, 21 days. And 54 of it was fat, 2 of it was muscle. And why did he lose that 2 pounds of muscle? Well, next time you're at the gym, grab 2 25-pound plates and walk them around for a day, and you'll see that you need more muscle to carry them around. He lost the muscle because he didn't need to carry the weight around anymore. So the whole myth that, hey, you're going to fast, your body is going to eat itself is very false. The other thing that happens about 32 to 34 hours is your metabolism increases by about 12% because your norepinephrine and epinephrine levels go up. And that's to focus you. Think about it. We're on the savannah. I just stepped on a stick, right? I screwed up. So tomorrow, my body's going to say, man, you need to be a little more focused. You need to maintain your muscles so that we can track an animal, and you need to make sure you don't step. So now I'm laser focused. And that all happens. Not saying you have to fast. I'm just saying it's one of the things that, because of that study, they've come out with. So that's diet. The biggest thing about diet, though, is truly that I've found doing this for the last 8 to 10 years is that this right here is the most important statement, what the patient will adhere to. You know, I have to modify my whole diet from my Filipino population. You know why? Because they eat rice at every meal. Every meal. I don't like people eating rice. It causes insulin levels to go up and causes fat storage. It's very hard to do, but I also have to be culturally sensitive. So we say I allow them to eat rice, but only the amount of rice that they would have eaten in the Philippines, not the amount of rice that they would eat in America. So, fair enough? So that's diet. What's the second biggest leg of the table? Sleep. Anybody else? Exercise. Exercise. Anybody else? Believe it or not, she got it. Sleep it is. Sleep, uber important. Everybody underestimates sleep. Poor sleep increases insulin resistance. It also helps control two hormones. One's called leptin and one's called ghrelin. They're evolutionary hormones. Leptin is a hormone that decreases our appetite, but it increases our metabolism. Ghrelin is the exact opposite. They're teeter-totters. One goes up, the other one goes down, and vice versa. Ghrelin makes you eat everything in sight. There's not going to be a food safe around you. And it also slows your metabolism down. Okay? So if you think about it, in calorie in and calorie out. Everybody seems to know what calories are. Leptin is not a lot of calories in, a lot of calories out. That's what we want. Okay? Sleep controls these. If we sleep 7 to 9 hours and we don't have obstructive sleep apnea, we upregulate ghrelin or upregulate leptin. If we sleep less than 7, greater than 9, or we have sleep apnea that's not being controlled, we upregulate ghrelin. Now, these control, so if you and I were put on a deserted island and we had airdropped in 800 calories a day, we'd all survive. We'd all probably lose a little weight until we got down to our genetically programmed weight. But as we have evolved, our body realizes, holy crud, there's a lot of emergencies that happen. What happens if you break a leg, or I get a pneumonia, or we have to run from an animal, or it starts snowing on our island? You know, we have to produce extra energy. So throughout evolution, our body adapted to take in and store more calories. So we only need 800 calories a day. The average American, I'm just being nice, we eat between 2,000 and 2,250 calories a day. I was nice and did because I'm not good at math. Doctors are never good at math. 2,000 minus 800, you get 1,200 calories. This extra 1,200 calories is controlled by leptin and ghrelin. So if you're not sleeping, you're not burning them extra calories. You know, I always ask people, why do women who breastfeed, you think about kids, you know, they come out and they're about this big, they fit in your hand, right? And then by a year, they're running around terriers, right? They're about yay big. It takes a lot of calories to get somebody that big. Why don't women just fade to nothing while they're doing that? They're giving all these calories to the offspring. Well, what are they doing every 3 hours? They're up breastfeeding, right? So they're not sleeping. So think about this. Perfect evolutionary hormone. Mom's eating for 2, but she's sacrificing her body for her infant. And when we don't sleep, you'll eat terrible food. I used to deliver babies when I first got out of residency, and babies always come at 2 o'clock in the morning. I don't know why they never come at 2 in the afternoon when you can blow off a little clinic and have a little free time. But no, they don't. 2 o'clock in the morning, so right as you're going to sleep, the labor and delivery, hey, she's at 8, come on in. So you go in and deliver around 2. By the time you clean up the mess and do the charting, it's about 4, and then you drive home and right as you're getting to sleep, the alarm goes off, you have to go back to clinic, you do clinic, and then at 12 o'clock, you go over to the hospital, do rounds, and check on baby and mom, and then, it's lunchtime, so you go down to the doctor's lounge. You would think the doctor's lounge would have the healthiest food on the planet, right? Have you ever been in the doctor's lounge? Terrible food. Ho-hos, Twinkies, ding-dongs, donuts, brownies. Here I would be teaching this stuff, and I have a donut in my hand because I've been up for the last 40 hours, and my ghrelin levels are up. Remember, these are hormones. This is just like trying to tell, like telling a teenage boy, nothing's going to happen in math class. The guys get that joke probably, but or telling a woman, hey, when you get your period, you can't change your mood. This is the same thing that's working. I usually don't have to explain hormones as much to women as I do men, but this is what that's equivalent to. You will eat even though I think I have great willpower. I teach this for a living, but still I had the donut in my hand, and it's hormones. Fair enough? So when I talk to people about sleep, a lot of people will tell me, hey, doc, I've never slept more than 4 hours. I'm not going to sleep more than 4 hours. I say, hey, I'm not here to argue with people. I try not to argue with too many of my patients. I say, how many miles, do you know how many miles you have to run in order to burn off 1,200 calories? Guess?
20.
Close, but not quite. If we were walking, maybe, but running, about 8. When I get off of work and I go run 4 miles, the little computer tells me I burn about 600, 620 calories, okay? So that's 4 miles, double that, 1,200, that's 8 miles. 8 miles. So I tell my patients, you owe me 8. You either owe me 8 miles of running a day, or you owe me 8 hours of sleep a day. One or the other. I don't care. If you want to stay up for the extra 4 hours and run 8 miles, hey, more power to you. Go for it. Totally okay with it. That's how many calories you have to burn. So you owe one or the other. It's your choice. It's that important. I spend a lot of time talking about sleep because sleep is so underestimated in this country, but it's very important. Since you guessed 20, how many miles you have to walk to burn a supersized number 1? Do you know?
Burn a what?
Supersized number 1. Big Mac, fries, and Coke. Try not to say names, but
Sometimes I walk 5 miles and I only burn 400 calories.
But how many do you need to burn a, believe it or not, it's 22. So the question I have for you, you mentioned exercise being very important. How many people would run 8 miles a day if they're not sleeping, or walk 22 miles if they're eating bad? Not going to happen, right? That's why diet and sleep is so much more important than exercise. Because there's no way you're going to out-exercise poor sleeping habits and poor eating habits. Go ahead.
When you talk about sleep, what about just resting? What if you can't actually go to sleep? Is it helpful just to lay there and rest? No, you gotta be out cold.
Well, I don't know about out cold, but you have to be sleeping, yes.
Yeah.
And it should be consolidated, which means taking a 2-hour nap or 4-hour nap and sleeping 4 hours a night. No, that doesn't count. It needs to be 8 hours. Now, I'm not talking about, hey, it's hard to go 8 hours without getting up and go to the bathroom. That's not what I'm talking about. But it should be 8 hours consecutively. Go to bed at 11, get up at 7. If you're going to bed at 10, it's really hard this time of the year in Alaska, right? I'm out in the garden until like midnight. My wife's saying, hey, you know what time it is? So I'm a realist. I understand that. But I also know that when you don't, stay up one night, don't go to sleep. See what you eat the next day. I mean, we've all had that moment where our kids called us in the middle of the night, or we had to deliver a baby or do something, and we were up all night. The next day, there's not a processed carb out there that's going to be safe, and that's because the ghrelin is telling you, and it's controlling it. It has nothing to do with willpower. It has to do with Mother Nature. She knows that there's some kind of stress in you that made you not sleep. So they're trying to gain calories to deal with that stress that's coming up. Does that make sense? If you can't sleep 8 hours, I know a guy named Dr. Triplehorn. I think he's giving a lecture here shortly, right? You should come to his lecture. Stress, let's talk about stress. Stress is important because stress releases cortisol, which also causes glucagon and insulin to be released, which glucagon causes glycogen, which is sugar, to be released, which insulin, which is a fat storing hormone. You have a perfect storm, okay? So stress eating, major contributor to obesity. The other thing is, this is sort of hard to talk about, but when it comes to obesity, we have a lot of people who have had past traumas, domestic violence, sexual abuse, ACEs, which is adverse childhood events. We really need to talk to people, and it's a hard question to ask when you're in the room, but you'd be amazed at how many people have that baggage that, if it's not addressed, can cause some dysfunction down the road. So we usually send them to counselors and get that dealt with. Next is exercise, okay? It's the smallest. I tell people this when they come and see me. I say, this is the importance of things. Diet is uber important. I mean, as they say, if you're eating Twinkies, Hoes, and Ding Dongs and swilling them down with Mountain Dew, there's not a lot of help. Next, if you're not sleeping, hey, that 1,200 calories. Stress and anxiety is pretty important. Exercise is this important when it comes to weight loss. Now, I think exercise helps with stress. It also helps with sleep. Exercise a little more, you'll sleep better. But exercise goes from this important to this important when it comes to weight maintenance. The National Institutes of Health did a whole bunch of research to help or to find out why people couldn't keep off, they kept regaining the weight, and they found the one thing that prevents it is 300 minutes of exercise a day. So that's where this 300 minutes comes from. Steps, everybody's into the steps nowadays. There's like 3 or 4 different societies that have said any steps below 10,000 is considered sedentary. 10,000 to 15,000 is considered mildly active. 15 to 20 is moderate exercise. If you want to consider yourself active, it's greater than 20,000 steps. So this is our table. Why are we building a table, you might ask? Well, the reason we build a solid table is to put medications on. I can give you every weight loss medication in the world. If you're eating Hoes, Twinkies, and Ding Dongs, you're not sleeping, you're all stressed out, and you're a couch potato, I can give you all the meds in the world. They're not going to help you. So medications, here are the FDA. There's 2 different categories of weight loss medications. One are the ones that are FDA approved for obesity, and then there's the ones that are FDA approved, but they're not approved for obesity. So the ones that are approved are the old standbys, phentermine and the other amphetamine salts. You've got heard of fen-phen, phentermine, Lomera. Those basically work by increasing, they actually suppress appetite and increase metabolism just a little bit. The downside to phentermine is the FDA actually states I'm only allowed to keep you on it for 3 months. So what the Qsemia people did is they came out with phentermine and put topiramate and called it Qsemia, and that I can give you long term. Topiramate's an anti-seizure medication. It helps people lose weight. It also helps decrease the side effects of phentermine. The GLP-1 receptor agonists, they're the big guns nowadays, Wegovy and Saxenda. They work on your brain, they work in your stomach. These are great weight management. I actually have a slide on that, so I'm not going to belabor that point too much. The next one is Bupropion and Naltrexone, which is Contrave. It works in your brain and your arcuate nucleus to decrease your appetite. And then Orlistat is it stops your body from breaking down fat. It works in a lipase in your stomach. Really great drug. It's a drug that all weight loss medications are judged by. You have to beat Orlistat in order to get it. The problem is if you decide to eat half a bag of White Castle burgers and you have Orlistat, you're going to be that fat one in the top is going to come out the same way on the bottom, and it can cause some problems. Off-label drugs, we could use metformin, which is actually the #1 prescribed weight loss drug in America. 80% of all weight loss doctors use metformin as the first line. Everybody who wants to live to be 127, which should be the average length in about 20, 30 years, or average lifespan, is taking metformin. SGLT2s, they help your kidney release pee out glucose, so it decreases weight by peeing out calories. Bupropion is the same as the Contrave, but you can give it to yourself by itself. It helps the arcuate nucleus, and then topiramate is the drug that is in glycemia, and it helps with decreasing appetite too. The GLP-1s, I'm sure you've probably heard of these in the news. They're what you can get if you go on a website, all the webs like Calibrate and Found and all those. They guarantee to give you GLP-1s. They're good drugs. This is semaglutide, which is Wegovy, is the big one. As you can see, 50% of the people who take it on the 2.4 milligram will at least achieve a 15% total reduction in body weight, which is as long as you take it. And the other thing is, remember back at that slide we talked about the fat mass. Once you get rid of that, once you break the cycle there, sometimes people can come off it and be totally okay. That's a tricky question.
So how long has GLP been used like this?
How long has GLP's been around? The first GLP-1, which was Victoza, is just coming off patent. It got a patent extension. 7 years is a patent. It got a patent extension 2 years or 3 years into its thing, because they got a pediatric indication for it. So it's supposed to come off patent next year.
So it's been around about 8 years?
9 years, yes. Yep. This is how GLP-1s work. They help slow gastric emptying down. They actually decrease appetite in the brain. They actually decrease your liver from producing, it's called gluconeogenesis or glucose production. It helps your muscles uptake insulin more, insulin sensitivity, the opposite of insulin resistance. This is one of the drugs that will help prevent that. It also helps your pancreas increase beta cell proliferation, which is what your insulin is. So it works in a lot of good ways. The GLP-1s also, some of them have MACE indications, which is major adverse cardiovascular events. These actually decrease your risk of heart attacks, strokes, and other vascular diseases. This one, I don't know if you guys were riding on the, this is an added slide. It's my last slide that I added. And the only reason I added it is today on the radio on the way to work, they were talking about this drug. It just got approved. It's a drug that is a combination GLP-1 and GIP-1. So it does everything that Wegovy does, plus it has another ingredient, a GIP, in there, which is the glucose-dependent insulinotropic polypeptide. And this is the Surmount Trial, if you want to look at this. This is what it achieved. So, 71% of the people in that trial got a 15% weight loss. So, if you look at 15%, Wegovy only got 50% at a 15% weight reduction. This one actually got 57%. or excuse me, 71% at 15%. Pretty remarkable that when we talk about weight management, people who lose 10% of their total body weight are doing really good. 15, you're in rock star status. 20%, you're in super rock. I mean, you're a superstar because it's very, very hard to lose weight. But 57% of the people with this medication were able to do it versus only 3 in the placebo group. This is actually equivalent to bariatric surgery. That's why everybody's really excited about this drug. So instead of going and having your gastric sleeve or your bypass, you can go on this medication. And this doesn't alter your absorption for the rest of your life. These are the other targets. We're not going to get into this because I'm out of time. That future drugs will be on, or you want to take a picture of that. This is the other areas that they're looking at drugs for. These are the 2 societies that are associated. If you go on either one of their websites, they actually have an algorithm that has all of the combined research of obesity studies in an algorithm. It's pretty cool what the society did. And then these are all my references. Fair enough? Any questions? Oops. Any questions?
Other questions? Big hand for Dr. Pierce.
Thank you.